step away and let you guys do your thing.
Thank you.
I didn't know if somebody wanted to start. Does anybody want to offer to start?
I guess I can.
Okay.
I'm kind of incompetent doing screen sharing and stuff though, so let me see if I can do this. Am I sharing? Can you guys see me? Or
Yeah. No.
okay, you can see this? All right.
Yes.
So I was a total geek and made this like document until I realized that we weren't really necessarily supposed to do this. But I had Choosing Wisely imaging, and I made this like little cheat sheet thing, and it basically goes through what Choosing Wisely is, and we were introduced to that in our module. It's an initiative sponsored by the American Board of Internal Medicine, and they've partnered with Consumer Reports to create some resources for consumers. And they have a campaign goal to reduce waste in healthcare and promote physician-patient conversations about avoiding risks of unnecessary tests. And so it's broken down in this little cheat sheet to some of the recommendations that came to the patients in the form of really client-centered information that you can share with your patients in your office setting. And I think there were something like 13 recommended recommendations related to imaging. And then it goes into the specialty groups. There are 70 of them that have contributed, made recommendations for the overuse of tests and treatments. And there's a website that we've had in our course module that has a link for patients and clinicians. So you may have visited that, and some of you, I think, are doing other areas of Choosing Wisely. So I have listed on here that it's in the Google documents that you can download if you're at all interested. But for the patient, there are 13 recommendations related to imaging. The first one is related to women with breast cancer, and then it goes into whole body scanning for screening for cancer. And a lot of these recommendations really are related to the fact that there's more harm that, I mean, if you're ordering a test and you find what may end up being an insignificant finding, it may delay procedures, it may cause a lot of worry and anxiety and lead to further unnecessary testing. So the first one, as I said, is treatment for women with breast cancer, and then it makes recommendations of who's at risk and who really needs this. And then in all other cases, you should avoid an MRI because there's no evidence that it improves treatment outcomes. The whole body scan, there's no evidence to support this for anybody because the exposure to radiation increases your risk of cancer, and it's also very expensive and unnecessary. And there's another one with imaging tests for chest pain and cardiac screening. There are actually several related to heart disease. I'm a nurse midwife, so this is like totally out of my realm, but for any of you that are in family medicine, internal medicine, this may be more appropriate to you. But it basically makes all these recommendations related to cardiac screening, tests for heart disease after a heart procedure, tests for chest pain. Basically, in asymptomatic people, it's not indicated. And here's heart imaging before surgery. This is really interesting because so many people go in for low-risk procedures. I think there's an example in a module or something too where you could go in for knee surgery and be fairly healthy individual. Oh, it's not hop replacement, it's hip replacement. Sorry, I missed that. But you can go in for, say, a knee surgery and end up having and this is heart imaging in particular, but If you find something, a little spot on somebody's lung, and it turns out to be something benign, but it delays surgery and it's uncomfortable, and anxiety provoking. And then they get into also imaging for early breast cancer. Here again, exposure to radiation and costs and increased false positives. If a woman already has cancer, recommend a mammogram annually and then every 6 months. Later stage cancer, they may have additional scans. Imaging for ovarian cysts. This is, like right up my alley here. Upon an abnormal exam, and then you can order a vaginal ultrasound, but if the cyst shows no signs of cancer, then it's not necessary to continue to repeat this. And I see it all the time in my practice setting that I guess it's CYA. And here's something of interest, imaging tests for headaches. I see people getting CTs and MRIs all the time to rule out, aneurysms and tumors and things. But most headaches are stress related, and really once, it's not necessarily indicated to have any kind of imaging unless you're at risk. And here's imaging for low back pain. I mean, you walk into any chiropractor's office and they have their own x-ray machines. And so a lot of people have imaging, especially x-rays, and I've had an MRI after an accident of my back. And imaging is very expensive, and again, exposes you to radiation. And people who have these tests do not get better faster, and imaging is more likely to lead to surgery and other unnecessary tests. Going over to the clinician's site, this was way too lengthy to summarize, but I do have, you can go to anything and search it on their site. There's 70 different society recommendations. So here's, I just put a couple of examples. ACOG do not perform perinatal or prenatal ultrasounds for non-medical purposes. We have 2 imaging centers in Reno, Nevada, the Open Air Imaging and Baby Pics. One is owned by a radiologist who has nothing to do with OB, and another one is owned by a perinatologist. So if somebody's adamant that they want those cute little 3D, which I think are weird looking, these ultrasounds and imaging, then I recommend that they go to the perinatologist, because I've had people come back with really strange quarters around the neck and they're freaking out. And if I have a perinatologist who calls me and tells me that, I'm more likely to than just somebody who doesn't do OB ultrasounds very often. So you can just click on a society name and you'll be directed to the full recommendation. There's labs, meds, procedures, treatments to avoid for that actual specialty. And then the American Academy of Nursing also lists 20 things that nurses and patients should question. There are also a bunch of learning modules that are for clinicians on how to open conversations about tests, things to improve our communication skills. And there's also a resource tab to a whole bunch of other different organizations. There are guidelines and toolkits that have been created for implementing Choosing Wisely campaign in your workplace. And there are 9 links to different organizations' resources of the guides and toolkits. It's been a while since I wrote it. Anyway, this toolkit can be found at this link that I provided in this. And then one of the recommendations, can I get out of this without, I'm really not very, I'm going to try to get out of that one and get into this one, and it's the Academy of Radiologists or something. Pull it up. It's taking its time. Okay, so the American College of Radiology, 5 things physicians and patients should question, and then it just reviews the one about headache, Oh, imaging for PE. I see this all the time with my pregnant women who have shortness of breath and freaking out and have chest pain. They're doing a bunch of imaging. This, again, the preoperative chest x-rays in patients without any risk factors, and CTs for suspected appendicitis in children, and then again the adnexal or ovarian cysts. And I'm going to try to stop sharing. Uh-oh, let me get.
Thanks, Slim.
And that's, yeah.
Does anybody else want to go
Anybody
next?
else want to go next?
I can go next. Hello?
Yes,
Hello?
okay.
Okay, this is Vanessa. Actually, I'm talking about tests as well, but this will be blood test. Patients usually have many tests during clinician visits and while in the hospital, and I see this a lot at the VA that I work, especially when they're 100% connected. They just order tests and tests and tests. Even sometimes someone had ordered like chemistries or anemia studies. It takes at least 3 months to see a change in the results, but then you see another provider come in and order the same CBC and the same, iron studies, and you like, it doesn't make any change in the result or in the management. Though sometimes the patient needs all these tests, they are not needed in every case, as their results may not change the outcome. More testing doesn't usually mean it will help the patient, or less testing mean that it will hurt the patient either. There are risks for many blood tests, such as anemia, infection, and sometimes if they're in the hospital, less sleep. The resources that were explored was mostly the Choosing Wisely websites. And I found some recommendations from the American Society of Clinical Pathology that said, avoid routine preoperative testing for low-risk surgeries without a clinical indication. And you see that a lot, especially, for instance, when I have patients that are being worked up for transplant, especially when it's elective, they're doing clinical tests that it really doesn't apply, and you think, why are they doing this? Most preoperative tests, such as complete blood count, PT-INR, or BMPs, or UA, they perform on elective surgical patients. They're normal, and it will not change any findings. It was said that only 3% of the patients tested can influence the management. Preoperative testing is appropriate in symptomatic patients only, and those with risk factors for which diagnostic testing can provide clarification. Also, the Society for Healthcare Epidemiology of America recommends that do not perform urinalysis or urine culture, blood culture, or C. difficile testing unless patients have signs and symptoms. And a lot of times, especially when it comes to nephrology clinic, we do a lot of UAs to figure out the kidney disease stages and hydration of the renal function. You find people coming out and you see many bacteria or pyuria. Next thing you know, they're ordering cultures when it's actually not needed. It's just wasting a lot of money. The actions that were outlined by the Choose Wisely website, where patients should not be afraid to ask their doctors several questions, like, do I really need this test? Would the test help in changing the outcomes? What are the downsides? What are the risk factors of doing the test? Another question patients need to know to ask, are there simpler or safer options instead of doing the test? And what happens if I do nothing? Because sometimes you do the test, what do you do after that? Will it change your plan of action? And how much does it cost? Because a lot of days end up with patients having to pay co-pays and things like that. I am going to share some tests that from the Choose Wisely website. I pulled out a Consumer Report Health medical test questions that could help patients process of testing to, let's see how I can get this, to avoid medical testing when it's not needed. And this is like a guidelines for patients to use. I am trying to get that up. Can you all see my screen? Did it come up?
It is, yes, it's there.
Okay, so this was like questions that actually is said some of the medical societies that participate in the Choosing Wisely campaigns, they pinpointed 3 tests that usually people just get done, ordered and do them when it's not really necessary, like the bone density test. According to this report, when patients, this is like a flyer for patients to know more before they go. It says if you're less than 60 years old, it's not needed because 65. It's not needed because it does not change the outcome. And then they're talking about EKGs and exercise stress test. If you're asymptomatic, there's no reason to do that. And another testing that they talk about is the allergy testing, which sometimes they say if you don't have a doctor actually do an exam, do not agree to allergy testing. And I can attest to this. I remember when my son was about a year old and he started developing a lot of hives and rashes, and they wanted to just put us through allergy testing without really having a physician examination. And I was so glad I said no to that. At the end of the day, it turns out it wasn't allergies. So a lot of times in hospitals and even clinics, you have tests that patients really don't need to undergo that because it can create a lot of anxiety, more testing, end up doing even procedures that you're not supposed to do because of the test results. As clinicians, we're trained to react when you see an abnormal result. Sometimes it's not needed, so it is advisable to avoid them instead of going ahead and doing those testings when it's not needed. I think that's it.
Okay, thank you very much. That was helpful.
I'd like to go next, Allison, here, if I can.
Okay, great.
Let me share here. Okay, can you guys see my screen? I can't see you, so I'll need. Okay, thanks. All right, so this is the Ottawa Personal Decision Guide, and what I was supposed to study was the Dartmouth Decision Support Tools. And it's actually pretty neat because it goes hand in hand with what Vanessa was talking about and a little with what Lynn was talking about too. It can be used in scenarios to help your patients understand the decisions we're trying to guide them to make, or also to help them feel good about the decision they're going to make. So you can see this here. I'm not going to go through the whole thing, but it's a really neat way to get the patient to say, what am I thinking? What are my options? And it's especially cool because the provider can lay out their opinion. Here's what I recommend. Here's what literature says about it. But what are your options? What do you want to know? Including the option to do nothing. So one drawback is, of course, this is a 2-page thing here. I'll just let you glance at it. Whoops, sorry. There's the options. Which option do you prefer? Who's involved in your decision making? How do they support you? It's just, you get the idea, and you can find this at this website that you can see there on the screen. And ultimately, it's to get them to feel good about the decision that they made. And what they found is when they used this decision tool or other decision aid tools, it decreased decisional conflict for patients. They felt more informed, like they understood the risks and benefits better. For example, they even had a video that showed a mom who her son had an ear infection, and the provider laid out all these options of here's why we can give you antibiotics, here's why we may not need to, and then kind of walked through a decision aid process to help the mom make the best decision. Because I think we often order tests, blood work, etc., prescribe antibiotics, because sometimes, let's be honest, we have to make the patient happy. And that's not a very fun place for us to be. And I really did like these tools. Even if you don't go and actually implement a 2-page tool in your office, there's some really neat things that you can take away to help talk to your patients. Let's see, I'll show you. This is a way to evaluate. So ultimately, there's a toolkit of how you can implement using patient decision aids in your office. And then you obviously need to evaluate that and see if it's getting better. And there's some really neat ones listed here. I have them up, I'm pretty sure. The traditional decision conflict scale, as you can see here. Did the patient know what the options were, etc.? There's some stuff. Am I sure of my decision? Do I feel informed? Do I understand? So you get the idea. There's lots of neat ways to evaluate this here. And I'll let you kind of look at this really quick, because if you wanted to go back to it, at the side here you can see there's a toolkit that lays out all the steps of what you would do. My favorite part of this, besides the actual Ottawa decision tool, was where is it? I got to figure out which one it's on. Sorry. Oh, I guess I have to click on it. I didn't have it. It was this inventory where you can go here, an A to Z inventory of decision aids. So let's say I chose obesity. I want to talk to my patient about bariatric surgery or something like that. And you can come here and there's all these different tools for you to use about, you can even send them home with your patient so that they can work through it on their own. Should I have weight loss surgery? And then you come here and it lays out all these things, and then you click here and you get the actual And I thought this was pretty cool. So again, you can go back and whatever topic you want to do. And I will show you one more because it was kind of what we were talking about. Like, I think we all see patients with sinusitis or something and they all want antibiotics, and do they need it? So there's some decision aids on should I prescribe and how to talk to your patients about that. And I just think that's a really neat thing. So I'm just going to show it to you and then I am pretty much done. Oh, they did one cool thing. So again, I'm just going to let you kind of glance at that because you can see the idea here. It's just some ways for you to be able to talk to your patient. So maybe you can get yourself off the hook a little better with them when why you're not prescribing, because some patients are really upset when you don't give them an antibiotic. So I thought this was neat. The last thing was one study. It wasn't just a study, it was a systematic review, showed that overall these decision aids do increase your visit length by 2.5 minutes, or about 7.5%. So that's obviously something we're always thinking about too, but okay, I'm done.
Thank you. Anybody else want to go next? I'm happy to go too if you guys want me to go. Yes? Okay. I'll go ahead and do mine. My name is Whitney Michael, and I work in Southern Vermont. I chose the Promoting Health Equity, a resource to help communities address social determinants of health. This was put out by the CDC, and this was a workbook to kind of go through a process to help help outline a problem that you see in your community and then steps to try to fix that. But basically, the workbook is 116 pages, and like I said, it's basically for practitioners that are interested in promoting health and addressing social determinants of health and health equity. I chose this toolkit because I live in a rural, low-income area in Vermont. Bennington County has a high poverty rate. It's about 13.5%, which is the same rate as the U.S. national ranking. However, the town itself of Bennington has a poverty rate of 15% and a child poverty rate at 18%. So we live in a lower income area. And so when we think about health equity, what exactly is it? It's according to Healthy People 2020, it's defined as the attainment of the highest level of health for all people. And so what is the social determinants of health? What are those? They basically are life-enhancing resources. So things like food supply, housing, economic and social relationships, and transportation and healthcare, so access to these things. And these factors have a direct correlation to the length and quality of life. So I know we've gone through this in the modules, and IHI has done a lot about talking about social determinants of health and health equity, that everyone should have access to quality healthcare. And so addressing these are really important because they do help increase people's lives and health outcomes. And I don't know if you guys went in the IHI module and you could go and type in what your county was from the county health rankings, and just see even from neighboring counties how different it could be. For example, in my community, a couple counties over, they have one of the highest ranked, the best ranked for health rankings. They're number 1. My county is a 13, which is as low as you can get on the scale. So, or actually 18 is the lowest on this, or sorry, 15 is the lowest on the scale. Ours was the 13. So basically, what do we know? We know that lower income communities and minority communities are less likely to have access to grocery stores with a wide variety of fruits and vegetables. Lower income, lower economic status is associated with increase for cardiovascular disease, diabetes, obesity, cervical cancer, respiratory disease, and things like housing inequities, homelessness, and transportation. These are all really important factors when we talk about social determinants of health. The workbook includes models and examples of communities that are working to improve health outcomes by addressing the social determinants of health. They discuss developing a partnership and to pool resources and to develop support. So it kind of goes through a stepwise approach on how one would even do this. It outlines a plan to create and assess and identify key steps to developing a partnership and plan to implementing it within your community. They give examples, and some of these examples are things like developing partnerships on a policy change with your community to enhance access to early education, and Head Start programs, for example, literacy group, things like that, or to address diabetes and obesity through community gardens, create safe areas through parks and recreation. These are just some examples that other communities have done. And I think that the workbook is a really great resource. It's pretty involved for one. I mean, this isn't really meant for one person to take this on. This is for a community approach. But I think as nurses and healthcare providers, we can certainly take pieces of this and learn about which things are affecting our communities and how we can make a difference. So for example, in my community, we actually have it's pretty safe. We don't have an issue with crime as much, but certainly access to care. And one thing that drew me to the place where I work is we work for the Blueprint of Vermont. So it's a medical home, kind of trying to meet most of patients' needs as much as we can and reducing costs. So our site where I work is already trying to kind of work on those issues. But if you guys want to learn more, it's the website is, like I said, is put out by the CDC. And oops, hang on a second. Sorry, guys. Hang on a second. I clicked on something and now I can't see you guys. Well, anyway, that was basically, I was going to show you an example, but now I can't. Okay, get back.
What's the name of the workbook, Whitney?
It's called Promoting Health Equity. It's a resource to help communities address social determinants of health, and it's put out by the CDC.
Thank you.
And I was going to show it. Hang on a second.
Can we ask questions?
Yeah, I think so. I don't know what's going on with me.
Whitney, that's really great. You know, I have a question. With the lower income and rural area, I work in Vermont as well. How do you get, in creating this partnership with the patients, how do you get them to show up? Because that's the problem we have. A lot of times they don't show up for appointments. They schedule, they don't show up. They don't even call, nothing. It's like they show up when they show up.
Yeah, are you talking about specifically for the workbook, or are you talking about through like the blueprint?
I'm just talking about like to work in partnership to help these social determinants. How can we, do you face that? Do you have that kind of issue of patients not showing up?
Yes, we really do. I mean, I think that, where in Vermont do you work?
White River Junction.
White River Junction. Okay, so I work in Bennington, obviously. And I think one thing that we have going for us over some of the other towns is that a lot of, you know, we have a kind of a large town in Vermont standards. We have over probably 15,000 people, which is pretty large for Vermont standards. And we don't have we have a big issue with people that live kind of outside of the community that are coming in.
Whitney, you're frozen.
I just realized we'd gone this whole time and I wasn't on the camera. Whitney.
It's something, Whitney is frozen. Whitney, are you still there? Okay. Do we continue? Maybe she joins us when she gets back. I don't know if she's hearing.
I think so. I think we should continue and she can join us.
Right.
Is there just one of us left? Is that you, Tansy?
I think so.
Oh yeah, she signed off.
So Tansy, you want to go ahead then?
Oh, Whitney's back.
Well, sorry guys, my internet connection disconnected. Sorry about that. My internet connection just disconnected for a second. But anyway,
to do with my camera on. I realized.
Yeah, I don't know. It was weird. But anyway, basically, I can direct you to the website if you'd like. I was going to screen share and give that to you really briefly. Let's see. Okay, so it's here. If you can see that, that's put up by the CDC. So if you want to copy down the link, and it might give you some resources. So anyway, it's I think it's a great toolkit to use as like a community and to be aware of what the social determinants of health are and how that affects your patient population. Anyway, anybody else?
Does anybody else see that? I don't.
You didn't see it? Did you not see it? I put it up and then I put it back down. Do you want to see it? Would you like to see it?
I don't think any of us could see it. It was just a black screen.
I saw it.
Okay, hang on, I'll do it again. Sorry. Can you see it?
I cannot.
Yes. Yeah, Winnie, is it the one with the people on their heads promoting health equity?
Yes.
I can see it.
Okay. So it goes through the whole thing. It's 116 pages, so I don't want to, go through the whole thing, but it does outline a plan on how one could go about doing that. And a large part of it is, pooling resources, figuring out where your need is, pooling resources, and then getting people on board to do it. And sometimes that may mean a policy change. It may not be just at the local level. It may be having to do things beyond that.
Thanks, Whitney.
Yep. Who would like to go next?
I think Tansy, you're the last one remaining, right?
Yes.
Oh, that's right. Yes. Who's the last one? Yeah.
Okay, I'm Tansy Hall, and I'm from Cott, Kentucky. I work at East Kentucky Health Services Center. We're just a small family clinic, and my topic is diabetes, which is incidentally my DMP project job as well. So let me see if I can screen share this. This has kind of been my Bible for the last little bit. Let's see here. I can get it up there. Can you all see that?
Not yet.
Did you go to screen share, Vanessa?
Tansy.
Nancy, sorry.
Yes.
Did you go to screen share? Up on the far left hand, there's a green arrow that says screen share.
Mm-hmm.
And then share entire screen.
Whoops. Let's see here. It's not.
You see the green arrow? Tansy, do you see the green
hover over on
arrow?
the left side till it comes up.
On the left side of the Google screen, right beneath Google, on the side of it.
Once you put your arrow there, the little sidebar will come up. And you want the green box with the right
or
arrow.
no?
No.
I did that, and I did the full screen and share.
So after you do that, click on the image that you want to share. You have to get off your screen. So go on whatever you're sharing, whatever the page it is, it'll be under your toolbar.
Okay. That is the image I want to share, but I don't think it's showing you all that.
The screen is black at the moment.
Let's see.
That's what it did when you were sharing, Whitney. I think Vanessa might have been the only one that could see it. So I wonder if there's just a problem and we're not going to be able to see it.
Interesting. Okay.
That's strange.
Let me see, just a second. Oh. Let me see. Look. I don't know how I can get this.
Can anybody see it?
No, it's just black screen.
Black for everyone? No one can see it.
I'm hitting the screen share. What?
Okay, Winnie, can you cancel from screen share and bring back your image? Like, stop sharing so we see you, then we start all over.
Can you see it now?
No. Can you stop sharing?
Does your camera have to be turned on? Because she wasn't on the camera before.
She's not right now. It's just the... Okay, there you go. You back. Wait a minute. Something is not right.
Is Whitney still sharing?
I don't believe so.
Let's make sure.
Winnie, are you still there?
Yes, I'm here. Can
No, Tansy, are you still there?
Yes.
Okay. I only see black screen when it comes to you. What is everyone else seeing?
black?
Yeah, that.
Black. When you click on Tansy, she's black.
Can you go out and come back in and see if that makes a difference? Just click out of it and come back in.
Let's see. Can you all see me now?
Okay. Yeah, I can see you.
Yeah.
Okay. Now let me see if I can screen share this. Huh. Okay. But whenever I go to screen share, it's not pulling up what I need. No.
Is it a document or a web page?
It is a document.
Is it on the Google Drive?
It is
Did
on
you
Google.
share it? Maybe I can go in and try to pull it out and upload it for you.
Let's see here if I can find it. Yeah, it's on my Google Drive as well.
Is this something that you can just talk about and then share at the end, the image? Or is it all what you want to talk about?
It's, let me see if I can get it to come up here. Now let's see if I can get it to share. Okay. Can you see it?
Yes.
Yes.
You can? Okay. It's all these documents are in my Google Documents if you guys want to go back and look at them. But like I said, mine is on diabetes care, and I just wanted to make a little geez, we just actually had this discussion in our clinic recently this past week. And I'm designated, since I'm the new nurse practitioner there, I'm designated to do well visits. And well visits are your age, your blood work you need, depending on your age. And
Is anybody else having a hard time understanding?
She's breaking up. I was just typing a note. Can Nancy, you breaking up?
Yeah, it must be your internet connection.
No.
I'm going to take a little break. I'll be right back.
Looks like Tansy is having such a hard time. Oh.
Can you all hear me now?
Yes.
Okay. You can't see the document though?
No, but I would just go ahead and talk about what what you found about your tool or what you're using, and if you'd like to make a reference to it, that would be okay.
Okay. I was talking about earlier about some of the comments you had made about unnecessary tests, and we just had actually this discussion at my clinic this past week about EKGs. I'm actually designated to do the well visits there, and we do, depending on age, risk factors, things like that. I make sure that they have all their EKGs, chest X, annual blood work or quarterly blood work or whatever it is that they need. And we were told by the insurance companies that these well visits would be actually paid at 100% and have zero copay, which kind of lures our patients back to do this well visit. Many times they don't like to come unless it's their appointment or they're sick. So this is like another trip to the doctor just for tests or labs or things like that. So we were told now that our EKGs that we've been performing on patients who have risk factors, positive risk factors, that they will not be covered, and that these can only be done in a physician. Talks about
Can anybody else having trouble hearing as well?
Yes, I don't hear her.
Okay.
Can't hear her.
Okay. I just sent a message in the text box there.
That's pretty good. I don't even know where the text box is. Is that up in the top on the toolbar thingy?
It's over to the far right. If you go over to the very far right of your screen, you should have a not if it's all maximized on you, but if it's like if you can see the other people as well on the bottom, and then over to the right should be there, the text box. Under group chat.
You have your screen has to be half, not full screen.
Yeah, you can't have the whole screen.
Oh, okay.
Can you hear me?
Yes.
Okay, I'm sorry about that. We've been in a storm.
It's terrible.
Yeah, we can't, unfortunately, we can't hear anything that you're saying. I'm sorry to say. Has anyone ever tried to call in? I don't know how to do that.
To call in who? Call Tansy?
No, I mean, I don't know if there's a way, like I know in when we're doing other Google Hangouts, you could call. I don't know how to do that though. But
I think that's on the BBB.
oh, is that only for BBB? I thought
I don't know, maybe you can do it in this too.
Thought there was a way to do it through Hangout. Okay, well, we'll try to wrap things up, and maybe she can get on before we're able to conclude. But I think everyone had some really great tools and did a lot of work for preparation. That was awesome.
Right. And then, like Allison, there was something you shared that was very interesting. The tool that you shared about how patients feel so pressured to doing, tests or imaging that they're not wanting to. That was really good. I thought that's really good to use, because that could help even us clinicians to learn not to really pressurize patients on agreeing to, suggestions if they don't want to.
Yeah, I thought the Ottawa decision guide was great. Very helpful.
Can you all hear me?
Back.
Yep.
Okay. I apologize again. Page 33 of the diabetes manual has nutritional recommendations. They are they even gives like the if it's an A, B, C, D recommendation. And on page 48 is really good whenever you have a patient that comes in and you can just look at their A1C levels and they're telling you, oh, my sugar really runs good. It's 100. And it tells you like the A1C levels and what they mean and what their blood sugars will be running. Pretty well what their A1C would probably run. And on page 61 of the document, it gives the medication table with all the new medications out there. It's depending on patients' ability to pay, depending on their insurance, if we have samples available, depends on what kind of medication that they'll take to add on as a second, third, sometimes or even a fourth medication. So that has been kind of like my Bible for the last 5-6 months. So I wish I could share it with y'all. I'll try to do it again so that way y'all can kind of see a little bit of what I'm talking about. It's really good. A lot of them have charts and they're really easy to go to. So you can use the charts without having to kind of read all of it, because it kind of reads like a paper, an actual paper.
Can you type the name into the chat box so maybe we could write it down and we could also reference it if we're not able to see it?
I'm trying to pull it up here. Hang on. And it's also in my Google Documents along with a toolkit too for diabetes care. It's got exercise information, medication information. Let's see. See if I can get it to come up for you guys. Okay. Can you all see that?
Yes.
Okay.
Yes.
Oh, whoops. So I'm going to go through these for you.
Who put that out, Tansy? The journal.
It's at the top right there.
The journal clinical. There we go.
Mm-hmm. Yeah, and I'll show you a couple of the, if I can get it to stay there. Kind of can't go that way. You have to kind of scroll down and it makes it harder to. But yeah, it tells you how to diagnose the disease and kind of pretty well all care. It's extremely complex. It takes a long time to. Well,
was this the toolkit that you used, or what was the name of the name of what you used that you were researching, or was it a particular tool?
There is a toolkit also too. I'll show you that as well. I was just going to show you one or two of the charts in here. That way you could see what I was talking about. See, it kind of reads like a paper. But and there's plenty of charts even for like pregnant women and everything in here for those of you who are midwives. It's useful to you all as well. I can get it to come up here. Right here is the like criteria for diagnosing diabetes. It'll have it like in a chart for you there as well. That's one of them, but there's several of the charts that I have talked to you about or kind of got to talk to you about without me breaking up. And here's the toolkit that I used. And it's really helpful for people who have mobility issues like I've seen in our clinic. Even if they can't do a lot of physical, like an exercise on a daily basis, it's recommended 150 minutes a week. But here is one of them. Here is a picture of one of the ones who are a little bit more mobile. And if you're not that mobile, there are other exercises too. On here, leg exercises, especially for diabetics. And it's for people who are kind of a little less mobile, you know, some of the ones that they can sit down and stand up and do calf stretches and things like that. And at the top, it also kind of conforms with the CDC, the 9-inch plate. And it has pictures too. So it's really easy for people too who have, you know, limited reading skills. There's pictures to tell them how to fill their plate. And it's got pretty good pictures in it.
Do you know if this toolkit is available? Do we have to pay, or sometimes toolkits are we just print it out, or sometimes they'll?
No, you should be able to print it out from my, because I was able to print it out.
Okay.
From the Google documents that I've got uploaded.
Okay.
It'll tell you here like how to plan for breakfast and lunch and dinner. And then up here at the top, it kind of shows a picture of what your plate should look like. So. And it's got things about medications. It's like, it's 37 pages long. So I only took bits and pieces out that I thought would apply to the patient if they were having trouble with whatever that you could pick from and choose from. You didn't have to use the whole kit each time. So.
Okay, well, thank you so much. That's a really helpful toolkit. Okay. Should probably just wrap this up. You want me to send an email to Nisa? Is it Nisa? Yes.
Nisi,
It's NIESSA.
Okay.
Yeah.
I have
So
email.
Winnie, are you sending the email to her?
I'll send her an email right now.
Okay. Okay, ladies, thank you. Great topic.
Thank you.
Yeah, good job, everybody.
Take care.
Okay, bye.
Bye.
Bye.